Respected National President, ISA, Secretary, ISA, State President, ISA, State Secretary, ISA, the President and the Secretary of ISA, Hubbali Dharwad branch, other office members of the Hubbali Dharwad branch, my dear classmates, my senior colleagues and junior colleagues who have assembled here. It's a great pleasure and an honor bestowed upon me to talk the oration lecture entitled P.N. Vishwanathan's Oration Lecture. Now let me start with my PowerPoint presentation. P.N. Vishwanathan is a great teacher. He is a friend, philosopher, and a guide to me. I know Dr. P.N. Vishwanathan as a postgraduate student between 1990 to 1993. During those days, he was a very tough man, an angry young man. We were all very scared to approach him. But he was a very good teacher who was teaching us the skills of anesthesia. Now, after 1993, after I passed out of KMC Hubbali, I joined Mysore Medical College and I was working with Professor N.V. Nagalakshmi. Professor N.V. Nagalakshmi was due to retire in 2000, and at that time, Vishwanathan sir got posted as Professor of Anesthesia at Mysore Medical College. And he was surprised to see me there, and he said, "Enri, egri idiri." I still remember those good words. Then I said, "Welcome, sir. Now we will have to share the responsibility of the department. Let's work together." He said, "Fine." Now, during the course of 2000 to 2007, he was Professor of Anesthesia at Mysore Medical College. But I noticed a lot of change in him when I worked as a faculty by the side of him. An angry young man at KMC Hubbali had mellowed down a lot, and he was ready to accept the things as they are, was not very insisting upon, and he used to carry everybody forward along with him. Well, we continued our journey together. We were ably supported by Dr. Radha, who had also worked with us at KMC Hubbali, and she was also there till 2002. And subsequent to her retirement, my association with Dr. P.N. Vishwanathan grew much more stronger. From the time he came and addressed me as Bandri, Egri, Idiri, the pronunciation to call me changed to Lo Venkatesha, Egidyo. I was happy that I was making a good progress in friendship with him. Then in 2005, we were interested upon taking up the responsibility of conducting the national conference at Mysore. And he told me, "Look, nee en martiya gotilla. All your time must be dedicated for the conference." I said, "Fine, sir, we will work together." Then it was a phenomenal success. We had around 4,000 delegates who had registered for the conference. It was a gala conference where we hosted a cocktail dinner along with social and cultural events on all the 3 days. There was a host of academic activities which occurred in nearly 15 halls simultaneously, and everything was appreciated by one and all. Now comes the glitch. Towards the end, the total amount that we had to settle down with various people who participated with us in the conference was approximately around 1.82 crores, and we had collected only 1.75 crores. So Vishwanathan said, "Aitu kanaya, mane mata ella marbeku innu. Prestige is more important. I am happy that the conference went well. Inne mane markondidu, let us settle the bill." Then I told him, "Look, sir, this is not the end of the road. Don't worry, we will do something." Then we went to JSS Medical College and we requested the Swamiji there. He was magnanimous enough to give us some money, and we could clear all the dues. So in 2007, Professor P.N. Vishwanathan sir retired from service and he joined JSS Medical College. I was in touch with him even when he was at JSS Medical College. We used to meet, we used to exchange our thought process and other things. In 2010, because of administrative positions that were offered to me, I had to move to the Bangalore. At that time, Vishwanathan said, "Lay, Elemari Kaitara Ilidyakano, why do you want to go to Bangalore and get caught in the middle of all these controversies?" I said, "Look, sir, God has given us an opportunity. Why not explore that area also? If I'm not comfortable, I can always come back to Mysore. Then he said, okay, go, all the best. Then during the period from 2000 onwards, when I was at Bangalore, I didn't really have much of an interaction with Professor Vishwanathan, but he used to repeatedly call me. He used to get many of his doubts cleared, especially with regards to governmental procedures. There were some problems with his pension and all, which I could get it settled. And once in a way, when I go to Mysore, I used to go to his house. His wife was a fantastic cook. She used to cook a lot of good food for us. And we used to chat for long hours, and I used to come back. But from 2012 onwards, because of my association with the various administrative activities, it was not that possible for me to go every time when I went to Mysore, but I was in touch with him through phone calls. And later on, as all of you know, unfortunately, we lost a great soul. So during my tenure, Vishwanathan acted like a teacher. He became a friend to me during his tenure at Mysore Medical College. He became a philosopher for me, the way he handled the ISA National Conference and his advice to me when I was going for administrative position. He continues to guide me with his philosophies. Next. Now, with this brief introduction, I will start my PowerPoint presentation. Actually, I just wanted to go ahead with Omicron, the current perspectives. My good friend Ravindra told me we are all fed up with COVID, and we are just not going to listen to that anymore. He said, why don't you speak on your strength, which is the medical education? So I thought that whatever he was suggesting was good, and I decided to speak on competence-based medical education, current perspectives. Now, I am going to take you in this PowerPoint presentation through what is the standard medical education program that goes on. What is this buzzword, competency-based medical education? In what way competency-based medical education differs from standard medical education? How do we implement complement-based medical education? How do we assess the efficacy of Cbme? What are the advantages of Cbme? And what are the challenges that we are going to have while implementing Cbme? Now, overall goal of any medical education is that when a novice who joins an MBBS passes through his MBBS course, joins a post-graduation, and subsequently few of them are lucky enough, they go for super specialization. And after completing their graduation, post-graduation or super specialization, they settle down for practicing. So when they start practicing, they need to fulfill 5 roles. They should be outstanding clinician. We know that whether you are an MBBS graduate or an MD graduate or a DM or MCH graduate, you need to practice. So you may practice in your nursing home, or you may practice in your clinic, or you may join a corporate hospital, or you may join any of the medical colleges. So whatever role is, you should exhibit your skills to ensure that the patients who come under you are appropriately treated. This is what we mean by the term outstanding clinician. Educator, a doctor needs to be an educator. Educator means 2 things. One is you should educate the people with regards to positive health, or you can be an educator who joins medical education and carries on the work of training the residents who carry the torch forwards. They need to be leaders. Earlier, doctors used to be confined themselves only to their practice areas, and they were not interested in leadership roles. But slowly, the things are changing. Whenever mass emergencies comes, especially like a COVID-like situation, there will be pharmacy team, there will be nursing team, there will be revenue people who will be helping, who will be wanting to help us. There will be so many other people, and they are all waiting for instruction from you. So you need to have leadership roles. Of late, many of the doctors are also taking up IAS positions, and they need to be leaders for effectively discharging their duties. Some of us will also be interested with leadership requirement, like I was the director of medical education. So there was a need for us to be leaders in policy making decisions. He needs to be an advocate. Advocate means it is not an LLB graduate. Advocate means you should advocate positive health. That is preventive, promotive, and curative aspects. He should also be a researcher. This is not very well appreciated field. I still remember when I was practicing at KMC as a student, I saw DTC, galamine, and pancuronium bromide as the muscle relaxants. At the end of my tenure at KMC Hubbali, I saw vecuronium bromide, and the expression I had, I still remember, wow, this is the great vecuronium bromide about which is read so much in theory. Like that, when I came to Mysore Medical College, a postgraduate taken in research on atracurium, and that was something very great. All the staff members used to look at that liquid and used to see how it reacts and how spontaneous respiration occurs with atracurium. So those are all the things which was possible because of the research that went on in the field. We have fantastic airway gadgets. We have very good monitoring equipment. We have very good anesthesia machines. All these as possible because of the research and has made our field much more safer today compared to the yesteryears. Now, traditionally, how was medical education taught? All of us know that we joined MD program in some medical college, and this, after joining this course, we were hooked on along with a senior postgraduate. We used to be the carrybacks of the senior postgraduate, used to go and do whatever he says. We used to observe him, and he used to teach us many skills in the operation theater. The teachers used to give us lectures. There were seminars and the journal clubs. In the first 6 months, we were expected to take up a thesis work, and we used to participate in the seminars and the journal clubs. Again, the senior postgraduates used to handhold us, saying, this is how you should prepare, this is what you should read. And in the end of the seminars and the journal clubs, the teachers used to ask us few questions, making us understand whether what we have read has entered into our calvarium or it is just that we have mugged few of the things. So in the end, there used to be a final examination consisting of theory and the practicals. And if any candidate scores requisite marks in the theory and the practicals, he was declared as passed and he was supposed to practice very efficiently the field in which he has specialized. I still remember in KMC Hubbali, the theory paper used to be evaluated by the same set of people who used to conduct the practical examination. And in case if we did practicals well, I don't think they really used to read the entire of the theory, but they used to pass us in the theory. Well, with the introduction of Rajiv Gandhi University of Health Sciences, this double valuation and other things, the theory component used to be evaluated by others and the practicals used to be evaluated by other team. And we had to practice both the things. I mean, we had to pass both the things separately to be declared as passed. So the net result of this traditional medical education was that it is a fixed duration of the course where knowledge acquisition was given more importance to. At the final examination, are you able to answer the questions that have been asked? That is knowledge acquisition. In practicals, there was no clinical demonstration of your skills. They used to ask, look, there is a huge thyroid. You want to anesthetize. What will you do? If the candidate says, well, I will lift the thyroid and I will try to pass the endotracheal tube beyond the site of obstruction and all, they used to be happy. But there was no practical demonstration of the skills. So in traditional medical education, the main focus was on knowledge acquisition, and the summative assessment was consisting of appreciation of the marks scored in the theory and the practicals to say whether candidate has passed or failed. Now, when this was the standard medical education teaching that was going on in the world, the Western world thought that this is not an appropriate method. They thought that knowledge transfer is not appropriate. We have got an information technology boom. Anybody can get anything they want as far as the knowledge is considered with a tip of their fingers by going through Google search or through PubMed or various search engines. So they thought that the knowledge transfer is not an important thing, but more important was knowledge application. So whatever you have earned in the knowledge, will you be able to translate it into skills for the benefit of the patients? So this was the thing which the Western world was thinking about, and it was embracing this change from knowledge transfer to knowledge application in its curriculum. And this led to the concept of concept medical education, competency-based medical education in India. Now, Lancet in the year 2010 followed up the changes in the medical education that has occurred over the last 70 years. Even in the beginning, the Lancet notes that it was a classical traditional method where teacher-centered knowledge applied to coaching was going on, and we used to produce an expert who is good both in knowledge and clinical skills. Then came formative assessment, where in addition to knowledge and skill, lot of value was given for social values. So this addition of social values for knowledge and skill is expected to produce a person called as professional. Now, knowledge, skill, social values, along with leadership qualities used to produce a person called as an effective change agent. This is the Lancet's description of how the landscape of medical education has changed over a period of 70 years. Expert with knowledge and skills, professional with knowledge, skills, and social values, effective change agent, knowledge, skills, social values, and leadership abilities. Now, I have told that the traditional teaching was associated with knowledge acquisition, whereas competency-based medical education was associated with knowledge application. So let us look at the differences between the two types of teaching. I told you with traditional, knowledge acquisition was the main thing. Teacher was the driver. He used to teach us, and we used to simply believe, and we used to by heart, or we used to read the textbooks. And in case if we have got any doubts when we were reading, either the senior postgraduates used to solve our problems, or the teacher used to solve our problems. And at the end of fixed time of 3 years, we used to take an examination, and we used to be declared passed or failed depending upon our performance in the examination. In contrast, in competency-based medical education, more emphasis is given for knowledge application. And here, it is not the teacher who is driving, it is the learner. Learner will be given a set of responsibilities or the competencies which he is expected to achieve before he takes up his final examination. So it is the attempt by the learner to achieve the competencies which are given more importance in Cbme. Here, both teacher and learner are responsible for the content. The teacher says us, these are the competencies which you need to know. These are the instructional materials I will give. This is what you should read and practice by yourself. The learner, after reading the instructional leaflets, then starts analyzing, starts practicing, and picks up the competency. So this sort of assessment is called as formative assessment. In summative assessment, which is practiced in standard medical education programs, there is one exam at the end. Whereas in competency-based medical education, the focus is assessment throughout the course of postgraduate period. Every week, every month, he has been assessed to know whether he is requiring competencies or requires any sort of support. If so, how the support needs to be given. The learner also feels, well, I am not making up for my competitive skills. I need to improve. So there is more learner-oriented activity in Cbme compared to standard medical education. Now, other important aspect of competency-based medical education is variable time in attaining the competencies. In standard medical education program, we used to have 3 years as a fixed time. Whereas in competency-based medical education, there are two types of learners, a slow learner or a fast learner. A fast learner is one who is capable of having both the knowledge and the development of the skills in a very short time. In contrast, slow learners are one where they may have very good theory, but the type of skill development they make may be slow. Some may be slow both in theory acquisition and knowledge acquisition. They require more time for reaching the required competency levels. So in competency-based medical education, frankly speaking, the duration should not be fixed. Once a particular person has achieved the competencies, then only he should be allowed to take his final examination. For example, in Canada, normally the duration of MD course is 3.5 years. Some people with competency-based medical education could complete it in 2.5 years. Some have taken 5 years. But the best part is when they come out, they are very confident people, very competent, able to discharge their duties towards patient care very perfectly. Now, having harped upon the terminology competence-based medical education, let us try to define what is this competence-based medical education is. Competence means the acquisition of sufficient knowledge, psychomotor, communication, and decision-making skills and attitudes to enable the performance of action and specific tasks to a defined level of proficiency. Well, if you really look at these words, they look very big and they sound confusing. But when we break this sentence into multiple parts, it looks very simple. Acquisition of sufficient knowledge. This is nothing but theoretical knowledge which you acquire by reading the books or through the learning methods imparted by the teachers or the senior postgraduates. Psychomotor. This is nothing but the skills, the ability to perform the intubation, the ability to perform a subarachnoid block, or ability to give an epidural. Communication. Communication means the way you communicate with your peers, the way you communicate with the patient's attenders, the way you communicate with other authorities in the discharge of your duties. Decision-making skills, whether should you give spinal subarachnoid block or should you go for a general anesthesia. This type of decision-making skills. Most important, attitudes, that positive attitude, caring attitude, empathy, and taking care of the patient needs. All these together contribute competence-based medical education. So if you further analyze this competence, more importance is given to knowledge, skills, communications, and attitudes. This is called as ATCOM, which is the core of competency-based medical education. Now we need to understand what is competency and what is competent. Competency means what needs to be done. Competent means one who can do it. In other words, the skill is competency and the postgraduate who achieves that skill is a competent person. Now, does competent itself makes you perfect? Well, that's a question mark. Let me explain this with a perfect example. Let's say that you are trying to learn car driving. So you go to a driving shop and you get an LLR done and you learn with a driver by your side, and then you come to the RTO's office, and in the RTO's office, they ask you to take a test, they ask you to take the car in a round, and they ask you to stop, then take it in the reverse and park it again. Well, this is a test to say that your competency is there for driving. So that is competency. That is, driving skill is a competency. Because you have passed the test, you are said to be competent. But with that level of competency, will you be able to drive that vehicle in Bangalore? In Bangalore, you know, there is hardly any space even for a cycle to pass between the two vehicles. Well, the bus driver is trying to jump upon to you. The auto driver is really giving you very little space, and in whatever little space that is present, a two-wheeler is trying to squeeze through. So unlike an RTO test where you are in a very stress-free environment and you are trying to drive in a very big lane with very minimal vehicles, here it is a different scenario. If you are able to drive in such a scenario, you are said to be capable. So there are some schools of thought. Competency by a competent person should be converted into capability. Now, when we speak of competency, I told you the important attributes are knowledge, skills, communication, and attitude. This competency is said to be present in 8 domains. And in 8 domains, 58 competencies have been identified, and a postgraduate is expected to cover all these 58 competencies to say that he is proficient and he can practice the specialty. Now, what are these 8 domains of competency? Patient care, knowledge of practice, practice-based learning and improvement, interpersonal and communication skills, professionalism, system-based practice, interprofessional collaboration, personal and professional development. Again, the terminologies makes us feel as though these are some things which are flying above our head. But let me take through these domains very briefly. They are nothing great. Patient care. What do we mean by patient care? We should know the pathophysiology of the disease. We should know the history taking, what relevant investigations that needs to be done, whether the patient is in an optimal state to be subjected for surgery and anesthesia, what are the likely anesthetic technique that's going to be employed in this patient, and what are the likely intraoperative and perioperative complications that I can anticipate in this. How do I take care of the post-operative pain relief, and what are the risks that are associated with this, and can I explain these risks in an efficient way to the patients and take them into confidence, and whatever decision that we are going to make with regards to the care of the patient is a shared decision. This is what we mean by patient care. Now the next domain is knowledge of practice. What is this knowledge of practice? Every day the science is changing. What is true today may not be true tomorrow. What is true tomorrow may change day after tomorrow. So there is ever-expanding science are there, and the benefits of this ever-expanding scientific approach is that more and more safer techniques and safer agents are made available, and you should keep your knowledge up to date so that you are going to use the best of the available practice and always follow evidence-based healthcare. For whatever decision that you take, there should be some amount of evidence to say that you are acting in a very responsible way for the care of the patient. The next domain is practice-based learning and improvement. Now, we all know that we do mistakes during the course of our practice. If somebody in anesthesia says that they have not at all come across any problem in the career of their anesthetic practice, it only means two things. One is he is extremely lucky, he just got escaped without any problems, or he has never practiced the field of anesthesia. So it is but natural that one who practices anesthesia will always land in a problem. It's not that problems are important, it is that you should recognize the problem, act appropriately, and try to solve the problem. Now, after the problem has been solved, you should sit back and think, why did this patient develop the problem? Was there anything wrong in my technique? Was there any deficiency in the knowledge? Was there anything which I did not monitor appropriately? All this is called self-evaluation. This self-evaluation will make the man perfect. This is what we mean by practice-based learning and improvement. Interpersonal and communication skills. You know that we are living in a world where we have multiple Google scholars who are trying to poke their half-baked knowledge with us. For example, if any person goes and sits with a patient attenders and tries to say something, they say, no, we have searched in the Google, this is not the thing that is important, this is the thing that is important. So in their best interest, with whatever little knowledge they have, they try to think that they are the experts in the field. At that time, you should have a positive attitude, try to clear their doubts and say that Google is not the ultimate. We have a structured training program in the best of the interest of the patient. This is what is better, and take them into confidence and have a shared decision. In addition, while practicing, it is very, very important that you should maintain comprehensive and legible medical records. You should demonstrate sensitivity, honesty, and compassion in difficult situations. For example, let us say that a person is admitted into an ICU and he is not doing that great. So you need to be acting in a very compassionate way with the patient attenders, saying that the best of the things have been done and we continue to do our best, but his condition is little serious and we hope that he makes a comeback, but we are keeping our fingers crossed. Professionalism. This is one domain which is very, very difficult to explain, but let me make some attempts to define what is professionalism. Professionalism is a responsibility towards the patient with adherence to ethical principles. patient needs to be put above the self-interest, and we have to respect for patient's privacy and autonomy. If I give an example of professionalism that may help you to understand it better, let us presume that you are doing an ICU duty and your duty is expected to get over at night 8 o'clock and your next reliever is expected around 7:45 and you should hand over the cases with brief explanation of what went in the morning time. And at the same day, you also have a party at your house by 8:30. All your relatives have come home, or you are in a hurry to go back home. Let us imagine a scenario for some reasons which were beyond the control. The reliever did not come. Can you just leave the ICU saying, well, my duty hours are over and I need to get out? No, you cannot do that. This is what you mean by patient need supersedes self-interest. So you need to keep the interest of the patient above that of your interest. I know it hurts. I know it is very easy to say. When you achieve this level, you are said to be a professional. When you take care of the patient's interest more than your interest, you have become a professional. Now, system-based practice. This is one more domain, very difficult to define, but I will make an attempt towards this. A system-based practice means you should make use of the systems available in the region where you are practicing. Let us assume in a government scenario, we have 3 sets like a primary care, a secondary care, and a tertiary care. Your anesthetic is posted to a primary care with limited amount of facilities available. Let us assume that a patient with a PPH comes to you with atonic uterus and she may require a large amount of transfusion and also she may also require a hysterectomy. The primary health center where you are practicing does not have all those facilities for rapid blood transfusion or the volume expansion fluids. At least you should be able to stop the bleeding by packing the uterus, trying to give ergometrin or oxytocin, make the uterus contract with whatever fluids that you have, try to resuscitate. You know that in a smaller area, very close by, there is a secondary care which is available, where an obstetrician is also available who can take care of the uterine component of the PPH and try to address the issue. This is what we mean by a system-based practice, where you should be aware of the systems that are available in your area and act in the best interest to ensure that that system helps in better treatment to the patient. It also means that you should be socially be responsible for the type of service that you give to the patient, keeping in mind the cost awareness. Sometimes we know that during a cancer treatment, there are targeted therapies which are available, which cost around 2 lakhs rupees every month, and it may not be possible for everybody to take care of that. In such scenarios, what is the risk-benefit analysis that you can give for a poorer patient who comes with that situation, and try to ensure that the best of the care within the available financial resources are made available to the patient. Now, interprofessional collaboration is another competency. Anesthesia is a team-based practice. You know that a diabetic patient, when he is admitted under your care, you may require a cardiologist opinion, you may require a nephrologist opinion, you may require an ophthalmologist opinion. So in anesthesia, many of the patients, especially the geriatric patients, they require multiple consultations with various specialists. So interacting with these multiple teams and in a very responsible way and reciprocative way with these colleagues is called interprofessional collaboration. In this interprofessional collaboration, one should understand what are one's roles and should not unnecessarily poke their nose into the domains of the other healthcare professionals. The last but not the least domain that is important in competency-based medical education is personal and professional development. So the importance is given for lifelong personal and professional growth. I told that science is ever expanding. It is never a static thing. When I started anesthesia in 1990, we had dreamt of failed intubation drill as a dreaded thing, whereas today everybody is so comfortable with video-assisted laryngoscope and so many newer gadgets that they do not get so much perturbed like us for a difficult airway. So, though I passed in 1990, as I'm still practicing in 2020, I need to get myself acquainted with these gadgets to ensure that patient safety is taken care of. This is what we mean by lifelong growth. And you should have a professional growth by attending to CMEs, conferences, discussion with peers, and going for fellowship courses, and ensuring that your professional skill development is up to date. You should also have mechanisms to respond to stress. We know that anesthesia is a highly stressful period, and I have seen many anesthetists really breaking down with this stress level. So you need to practice meditation, you need to practice yoga, you need to go for certain relaxations like morning walks, and do not quarrel at home, and make the situation little less stressful to you. Manage the conflict between personal and professional responsibilities. If you devote entire of your work only for professional responsibility, you know what happens at home. And if you put entire of your time at only personal things, professionally you may not achieve. So there should be a semblance of balance between personal and professional responsibility. Now, having discussed the 8 domains of competency-based medical education, let us see how we can implement competency-based medical education. The word competency itself is the basic core point in the implementation of Cbme. The 4 steps that are involved in the implementation of Cbme are identifying the elements of competency, program organization for mastery, preparation of teachers, students, and the institution, and the last is the assessment of the competencies. Let us look at each of these factors. Identification of competencies. How do we identify? It may be based on the healthcare needs of the community, or it may be used a Delphi technique for identifying the competency, or it may be through task analysis, or it may be through critical incident survey. Let us look at each of these. Determine the healthcare needs of the community. This is not particularly suited for as an example for our field. We can say that the healthcare needs are you should be able to anesthetize any patient from ASA grade 1 to 5 in any of the situations. What is this Delphi technique? Delphi technique means you have a group of experts who are professionally extremely competent, and these experts decide what are the level of competencies required for a postgraduate to say that he is competent enough to practice. What is this task analysis? Task analysis means there is one extremely bright anesthetist. You examine the tasks that are done by him, either at the time of endotracheal intubation, or at the time of subarachnoid block, or at the time of giving a peripheral nerve block, and define that as a competency and try to take it forward. Critical incident survey means if an anesthetist comes across a critical scenario, how does he manage that? So in what way that successful management can be converted into a competent to teach to the postgraduates. So these are the 4 ways by which the competencies can be achieved. But I am very happy to say that Medical Council of India have already identified the competencies that are required for the specialty of anesthesia. In fact, they have done the competency identification for most of the broad specialty subjects, and the further refining is going on, and very shortly, the committee constituted for this purpose may come out with the identification of the competencies, which are further revised compared to what is already present in the Medical Council of India website. Now, after identifying the competencies, next one is you have to program a particular curriculum so that the student learns that competency. Now, that learning process is divided into 5 steps. Specific learning objectives, development of instructional units, encourage self-pacing, recognition of competence levels, frequent assessment. Now, if I give an example for this, I think it will make the job easier. Let us say that your thing is to make the student understand the process of endotracheal intubation. Learning objective is you should know what are all the conditions where endotracheal intubation is indicated, where it is contraindicated, and how do we achieve the endotracheal intubation. So all the theoretical components of learning the endotracheal intubation is the learning objective. Development of instructional units. Now you say for achieving the endotracheal intubation, you should put the patient in the supine position with a head under the pillow, make the oral axis, pharyngeal axis, and the laryngeal axis come in line, take the laryngoscope, expose the larynx, if it is a Karma Klehan 1 and 2, you can go ahead with a straightforward intubation. All those things you give instructional units. Once these two instructional units are given, then the student has to read through these instructional units and he has to practice it on a simulator. And in case if he is doing any mistakes or if he is finding anything difficulty in understanding, you should try to help him to find out what mistakes he is having or what confusional status he is having, and try to solve that confusion and try to make him pick up the skill that is required. Now, recognition of the competence level is very important. The student should know that he can make a further progress only when he attains that level of competency. And as a teacher, it is your duty to assess whether he has achieved that type of competency. Now, having said that, the teacher has to assess. Now, what should be the role of the teacher in the complementary based medical education? Now, I told you in earlier days, the teacher used to be an active teacher and the student used to be a passive learner. Now, in competency-based medical education, the role shift. The teacher becomes a facilitator and the student becomes a learner. It is the student who learns and the teacher only facilitates him. Teacher is a planner for organizing the instructional material. He is a manager because he shows how the resources needs to be used. He is also a performance assessor to know whether you have achieved required competencies. The students also need to totally be involved in competency-based medical education. They should take the personal responsibility for learning. They are no longer passive listeners. They are actively learning. They should go for self-directed learning methods. They can go for various textbooks, acquire knowledge, and then come and practice on a simulator, see whether they have achieved the required knowledge, demonstrate to the teacher, and have a documentation that they have achieved this. Now, after the postgraduate does lot of simulator-based endotracheal intubation and also does on live patients, you need to assess whether this person is capable of doing it in a live scenario. Unlike simulation-based practice, where it is a stress-free environment, where he is not under any pressure and he is allowed his own time. Whereas in real life scenario, it may not be possible. So in the real life scenario, when he is practicing the technique of endotracheal intubation, you need to assess him. The assessing tools that are used in Cpme needs to be continuous and frequent. What do we mean by that? Today he may be able to intubate. Tomorrow he may not be able to intubate. I don't know. It may be a difficult case, or it may be a thin patient, but his malapati grade might have been 4. So you need to have a continuous and frequent assessment to say that the desired level of competency is achieved. It must be criterion based. What is criterion based? The criteria in endotracheal intubation is the tube has to be placed just below the vocal cords in the mid-tracheal position. Now, in case if you say that you have given a score of 3 out of 10 for an endotracheal intubation because he could only expose the larynx but he could not intubate, it doesn't mean to say that he has achieved a desired level of competency. This is what we mean by criteria-based assessment. It needs to be largely work-based. So you need to assess his assessment in a live patient rather than on a simulator. Now, the assessment tools should be having validity, reliability, acceptability, so many big terms. Validity means it should be desired to give the expected value which it is expected to give. For example, if you are monitoring, if you want to monitor oxygen saturation, probably you cannot use a ECG machine because that's not a tool. You need to use a pulse oximeter if you want to measure oxygen saturation. That's what you mean by validity. Reliability. Reliability means ability to produce the same result in multiple attempts. Let me give an example of an MCQ question. If the answer is B, whether you do it today or after a month or after another 2 months, the answer is going to be B only. This repeatability is called reliability. Acceptability. The tool that is employed should be acceptable both for the assessor as well as for the learner. Educational impact. In case if the tool finds out a mistake, it will have an educational impact in making the student understand that there is a problem in his ability to achieve that competency. So the tool that must be employed should also have an educational impact. Qualitative approach is always better. I told you, instead of grading him as 1, 2, 3, 4 to 10 scale, you should say whether he is good at competent or very good at competent or poor at competent. Some qualitative approach is better. And it is always better the assessment is done not by the only one assessor. For example, in the Department of Anesthesia, there may be about 12 teachers. Every teacher should assess the progress that is made by an individual postgraduate, and all the teachers must be capable of certifying that he has achieved the desired level of competency. Now, what are the various assessment tools that are available? Direct observation, the best. You observe the patient when he is giving, student when he is giving a subarachnoid block or when he is doing an endotracheal intubation. You can assess his ability to understand the subject with the help of a long essay or short essay or multiple choice questions or problem-based learning. One of the most important things which I feel important is peer assessment. Your friends are going to say, hey, you are doing great. You are capable of really be intubating any case. I will be more confident if you are around. That is the best type of assessment which I feel. Trainer's report, your assessor is going to give the report is also important. I do not give much of importance for logbook because in the logbook, we always write very rosy pictures. Now, how do we assess the skills? It is traditional in the examination, we give only theoretical questions and we ask him the knowledge with regards to the skill application. But very importantly, skill-based assessment can always be done by direct observation of procedural skills. This is called as DOPS. And you can also give a lot of clinical scenarios for the postgraduate and see in how he responds to these clinical scenarios. You can also assess the skill development through simulators, but DOPS is the best. Now, I told you the attitudes are also important for a postgraduate. So there is a necessity for a bedside manner assessment. So you need to see how he is explaining to the patients, what is the time taken by him, what is his body language, is he comfortable speaking to the patients, are the patients comfortable with him? All these things needs to be assessed. One of the important things which I have noticed is, in case if a postgraduate is holding his mobile phone and trying to answer to a question of the patient or the patient's attender, it's a very poor bedside manner. Now, this is a chart which shows how much progress has been made while assessing a patient with, a resident with regards to Cbme. He goes through 4 phases: knows, knows-how, shows-how, and does. Knows is knowledge. Knows-how is he knows how to apply that knowledge. He just knows. Shows-how, he is able to demonstrate it in a simulator. Thus, he does it in a patient. Now, knows and knows-how is cognitive or knowledge-based. Shows-how and does is skill-based. Now, let us give an example of this Miller's pyramid, which I just showed you. Knows. A learner knows the indications, contraindication, and risk associated with the placement of a chest tube. He knows that pleural effusion is one where the chest tube has to be put and the fluid has to be drained. Knows how. He also knows that he has to introduce a chest drain after giving local anesthetic in the mid-axillary line and poke it into the intercostal space. Loss of resistance is the thing. This is all knows how. Shows how. He does it on a simulator and he is able to place a tube. Thus, in a clinical scenario with a massive pleural effusion, he is able to perform one. This is what we mean by the Miller's chart of assessment of competencies. Now, there is another terminology which you should know, what is called as entrustable professional activity. This is again a bridge between the theory and the practice of the CBME. ಇದು ಸ್ವಚ್ಛ ಕನ್ನಡದಲ್ಲಿ ಹೇಳ್ಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ನನಗೆ ಇವನನ್ನ ಈ ಕೇಸ್ ಮಾಡಕ್ ಕಳಿಸಿದ್ರೆ ನನಗೆ ನಂಬಿಕೆ ಇದೆ ಇವನೆಲ್ಲದನ್ನು ಚೆನ್ನಾಗಿ ಮಾಡ್ಕೊಂಡು ಬರ್ತಾನೆ ಅಂತ. ಇದಕ್ಕೆ ಇಂಗ್ಲಿಷ್ ನಲ್ಲಿ ವಿ ಯೂಸ್ ಎ ವೆರಿ ಗುಡ್ ವರ್ಡ್ ಕಾಲ್ಡ್ as entrustable professional activity. So let me go into a bit of details of this entrustable professional activity. When a postgraduate student gets admitted to post-graduation, he goes through these 5 phases. He will be a novice. He doesn't know what it is. He becomes an advanced beginner. Then he goes through the phase of competent, then proficient and expert. A novice who does not know anything, advanced beginner trying to pick up the things, competent where he will be able to do it under direct supervision, proficient where he is able to do it without supervision, expert one who is capable of guiding others. At the first level, that is at the novice level, he is just an observer. The student just observes all the activities. At the level 2 and 3, at the level 2, he does it with direct proactive supervision. With level 3, he does it under indirect supervision. At level 4, he is ready for independent and he is ready to do the techniques under unsupervised practice. At 5th level, he is able to assist others in learning the EPA. Now let's look at an example of an EPA. The first year postgraduate MD anesthesia should be able to perform subarachnoid block. This is a level of competency which I thought of. So how do I organize a learning objective for this? The student should know the anatomy of the spinal space, the type of spinal needle, the Batten's principles of how the anesthetic liquid acts in the CSF, what are the various pain and the pressure and the touch sensations that go with the onset of spinal anesthesia, what are the consequences of subarachnoid block, what are the complications of subarachnoid block, and how do I deal with it? These are all subject matter. Now, after the subject has been well learned by the student, he is going to perform the procedure of spinal block on a simulator, and then now he is fit enough to go for a live. Then the student should perform a pre-anesthetic assessment. We should see what pre-anesthetic instructions has given, what is the procedure of SAB that is done by him, how does he monitor the patient during the subarachnoid block, whether the treatment that is given by him with the complications, is it appropriate? Then the teacher should be able to prepare themselves for assessing these, and the student should be able to follow this organizational chart and ensure that he attains the required level of competency. Now, at the end, we need to do an assessment whether he has achieved the goal of doing a subarachnoid block. There can be a formative assessment or summative assessment in this. The summative assessment, formative assessment is you know whether he has got the required knowledge with either MCQs or short questions. The MCQs, the spinal cord ends at what level? Short questions like what are the pain pathways that get blunted? Is it delta or is it C? Then short essays. So you need to assess his knowledge. Then you evaluate the procedure that is done by him on a simulator, evaluate the procedure done by him on the patients, and while performing the procedure, what was his attitude is something which we need to assess. So these are all the things which will go a long way in assessing competence-based medical education. When a postgraduate student in anesthesiology joins the residency program, he goes through 4 phases: transition to discipline, foundation of discipline, core of discipline, and transition to practice. Now, in transition to discipline, he is a novice. He doesn't know what are the facilities that are available in the institute, where is the duty room situated, what are the room number of his senior postgraduates, whom should he call in case if something is required. So in such a scenario, we should make him comfortable by making him consciously aware of the facilities that are available to him so that he becomes more confident. Usually he gets attached with a senior resident and he follows him sincerely wherever the senior resident goes. This is called a buddy call system, where the senior resident virtually guides the novice into the discipline. Next is foundation of discipline. After having worked with the senior resident for a period, senior postgraduate for a period of let's say about 3 to 4 months, the senior postgraduate says, look, if sufficient is sufficient. Now you become solo. You go, in case if you have any problem, I will be available either on this number or I will be available in the duty room. You come back and you tell. This is called a boot camp approach, where we are easing the novice to the specialty in a much more gentler way. During this period, if from buddy call, he starts taking solo call responsibilities. Now, core of discipline. Once he has become solo, he is much more confident. Now he starts getting into the discipline by anesthetizing patients in general surgical procedure, orthopedic procedures, ENT, ophthalmology, the super specialties, everything. First, he needs to get himself trained with simulation based, and then subsequently go ahead with live patients and ensure that the desired level of competency is exhibited before he is marched on to next level of competency. Transition to practice. This is the last phase of a postgraduate where he is as good as a junior staff member. The staff members are confident, even if it is a difficult case, we know that we can send him and he can independently manage. This is called transition to practice. Now, these are the stages through which the learning occurs. First, remembering, by hearting whatever you say, understanding, then after understanding, applying the techniques, analyzing the techniques, evaluating the techniques, and putting the techniques into practice. Now, competencies in the specialty of anesthesia has been divided into cognitive domain, affective domain, and the psychomotor domain. I am not going into the details of this because already it is available in the website of the MCI. Cognitive domain means it is only knowledge. Affective domain means attitudes. Psychomotor domains means the development of the skills that are required. So plenty of competencies put together is going to make a person competent enough to practice anesthesiology. These are some of the cognitive domains. These are some of the affective domains. As the time is really running short, I'm not going into the depth of this. All these are available in the MCI website, and recently they are updating even these skill development programs that are required in the specialty of anesthesia. Now, in the first 6 months, as the postgraduate enters in, he should be entrusted with only ACA grade 1 and 2 cases, and he should also be given graded responsibilities, and he should start with Malapati grade 1 and 2 intubation, very easy spinals, then make him progress towards the next difficult phases. In the next 18 months, he should be prepared to administer general anesthesia. He should go ahead with epidural and peripheral nerve blocks, and he should also be able to anesthetize various super specialty patients. In the last 12 months, he has to submit his thesis. He has to manage critically ill patients. He should get exposed even to intensive care unit. He should be capable of managing the chronic pain. So much and things are able to be achieved. Now, having said all these things, let us look what are the advantages of Cbme over that of standard medical education. All of us pass through the standard medical education. Are we bad? No, we are not bad. Then what is that Cbme has got a specific advantage compared to the standard medical education? This Cbme is a self-regulated, flexible learning option. I told you some of us are fast learners, some of us are slow learners. In a slow learner, you will be giving him more time. Second, it is a formative assessment where graded competence acquisition occurs. And in case if we are going slow or if we are not able to master a particular technique, always the teachers will help us to achieve that level. So, because by the end of the Cbme, we will be competent with all the competencies that are expected out of us, we will be more confident to practice anesthesia. And I'm sure that all of you appreciate a confident anesthetist is one who can really cater to the needs of anesthetic requirement of various patients. Now, what are the prospects and challenges? I told you in competency-based medical education, especially with regards to anesthesia, there are more than 50 competencies that have been described, and each of these competencies has to be broken down into objectives, and each of these objectives needs to be taught with instructional units, and each of these objectives needs to be assessed. So there is a lot of work that is required for the teachers with regards to preparation of the materials that are required for the implementation of Cbme. So this may complicate medical training. Though it is said that Cbme is only a time not fixed technique where the learner is capable of achieving the goals at whatever desired pace that he wishes to have. In net essence, it is not really true. I have not seen any patient, rather any resident who is taking 4.5 years to complete his MD, at least in India. The period is still fixed. We are going through the process of the implementation. It's a work in progress, and there are certain competencies which are very difficult to measure, such as professionalism, or is he going to be a lifelong learner. So these are all the challenges and some of the deficiencies of Cbme. Having said that, is Cbme bad? No, it is not bad. Cbme is a very thoughtful approach to develop physicians. The success of Cbme depends upon the presence of a supportive administrator, management, resources, and it requires proper planning. So all of us know that we have all gone through the structured training program. Are we not capable? I have few friends here, Shobha, Nadgowda, our Kalkeri, Band Shivkumar, all of them are very successful practitioners. I have many of my students who are spread across the globe who are doing extremely well. It is not that we were in any way inferior because we did not go through Cbme. But still, Cbme I advocate. I had a beautiful interaction with Ved Prakash Mishra, who is supposed to be the doyen who proposed this Cbme technique. He said, look, you just think of an infant who is about to learn to walk. Now the parents are scared. Parents are scared because the child may fall. So they just stand by the side of the child and they take care of the child. But at the same time, they encourage the child to walk. The baby may take 1 step or 2 steps, it may fall. Again, they make the child to stand, again it will walk. Over a period of a month, the child will be walking without any support, and the child will be smiling, and the parents will all be with the smiles. In the same way, in the initial implementation of Cbme, we may have lot of hurdles. But once the Cbme comes into its groove, and we are able to train our postgraduates in a very structured way, where they are competent enough in all the domains which I described, and they will be highly proficient and extremely confident to practice the specialty of anesthesia. I think we all are going to be extremely happy with it. So with this, I come to the conclusion of my time. Thank you. It's really a privilege. In fact, I do wanted to come to Hubbali, and I wanted to spend some time with my sister Shobha, and I also wanted to spend some time with Kalkeri and Bond. But unfortunately, because of Omicron, I wasn't able to come. And it was a long time since I took up this responsibility of delivering the lectures. Even in national conference, when they asked me to give a lecture, oration lecture, I said no, because I thought that I am out of the system, I should not be speaking on anesthesia. But Vishwanathan sir is one where I have lots of respect for him as a teacher, as a friend. Now, if I look at the slide presentation which I made in the Cbme, all of you, I'm sure, will be able to recall how Vishwanathan sir used to train all of us. He makes us to load thiopentone, makes us to load all the muscle relaxants, keep the IV line, take the IV line all by ourselves by applying a BP cuff, then administer drug all by ourselves, oxygenate all by ourselves, do the laryngoscopy all by yourself, fix the tube, how you are squeezing the bag in between, it is to your headache. But looking at all the techniques which P.N. Vishwanathan sir taught us, I sometimes wonder whether is this gentleman having the forethought of competencies or the skill development in the postgraduates whom he has taught. In this regard, my mind thinks that it may be appropriate to call Dr. P.N. Vishwanathan as the father of competency-based medical education, at least in anesthesia. Many of the postgraduates who are trained by him acknowledges the fact that he gave more importance for competencies, which today, in 2021 or 22, we are realizing is what is the need of the hour. So with this, I thank the organizers for giving me an opportunity to talk in this P.N. Vishwanathan's Oration lecture. Thank you, one and all.